Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I want to talk a little bit about something called mixed connective tissue diseases. And this is a condition during which one has, let's say, rheumatoid arthritis or lupus or something of that sort. And then out of the blue, a whole bunch of other symptoms develop. Sometimes those other symptoms develop first, and then you wind up finding out as you begin to evaluate the person, they either have rheumatoid arthritis or they have lupus or scleroderma or whatever. Or sometimes you knew they have this condition. Let's say, for instance, somebody has Crohn's disease or ulcerative colitis. And then, no, this is associated with diarrhea and that kind of stuff. But suddenly they started having joint pain and this and that, a lot of other symptoms. And it turns out that there's other conditions that evolve as a result of the underlying condition. So across the world, there's some 5 million people that have mixed connective tissue diseases. It is actually more common in black folks and white folks, but anybody, can get it. Chinese, Japanese, anybody can get it. And so what you have to understand is that what you see, what you're dealing with, may not be what's troubling the person the most. And then the different diseases that are associated with it, including, of course, lupus, scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, Sjögren's syndrome, psoriasis, arthritis, etc. So how do you know what's going on? Well, you've already diagnosed somebody, let's say, with lupus, which is what I'm talking about in last show, and then you got that under control, and then out of the blue, the person shows up with something they didn't have before. And suddenly, let's say they started to hemolyze. They have an anemia. I say, well, what is the anemia about? There is anemia of inflammatory diseases that are associated with lupus. We know that. But then why is the patient suddenly losing how his red blood cell count volume suddenly? They're not bleeding. And then when you evaluate that, it turns out they're hemolyzing. Well, the best way to evaluate the hemolysis, of course, is to do a reticulocyte count or direct comb test, or you do an LDH. You can't be hemolyzing and don't have elevated reticulocyte count. You can't be hemolyzing without elevated LDH. And then suddenly see what's going on here. It turns out that you have an overlap syndrome or mixed connective tissue disease. Overlap syndrome means that now all of a sudden you have another condition, which is autoimmune hemolytic anemia, which is quite common, and that's also called overlap syndrome. The same thing can happen. Somebody, you diagnose them with dermatomyositis, which is a skin problem, and suddenly they start telling you, well, my eyes are drying all the time, my mouth is dry all the time, and you evaluate them, you find out they have Sjögren's syndrome. That's mixed connective tissue diseases. So this stuff is very complicated. It's extremely academic in nature, but it is real, and it affects people. So you really have to know that. So the way you go about doing that, first of all, you would, for instance, the symptoms that are associated with the disease that you know about to begin with. In addition to that, you have malaise, fatigue, fever, joint pain, muscle pain, swelling of the hand, fingers, wrists, ankle, feet, elbows, and Raynaud's disease, that kind of stuff. That's when you become very suspicious that something is going on. And the organs that are most frequently affected, of course, are the lungs, the heart, joint, bone, skin, eyes, mouth, esophagus, stomach, small bowel, large bowel, and the blood system. So this is a very common problem, and you can miss it very easily. You're doing the best you can to treat, let's say, the rheumatoid arthritis. Everything is under control. The patient is responding nicely to medication, and suddenly things started going haywire. That's when you have to put your hat on. Number one, if you don't understand this, you don't know, you should refer the patient to a practicing rheumatologist who's extremely familiar with this, and they'll be able to diagnose it right away. Otherwise, if you let it go on and on and on, and then you get into trouble. The patient get into trouble. So you have to keep in mind that mixed connective tissue disease is really quite common. 5 million people around the world have that. And in this country is 1 person per 100,000. That's a common problem. And then you want to evaluate it. Well, you've already evaluated the patient for rheumatoid arthritis. You know they have that, or you know they have lupus, or you know they have scleroderma or whatever. But then you will proceed to do a physical examination. In addition to the physical examination, you will do blood count, complete metabolic profile, even analysis, set rate. You'll do an ANA, rheumatoid factor, anti-double-stranded DNA, ENA, anti-RNP, anti-ROSSA antibody, LASSB antibody, anti-Jo1 antibody, anti-Smith antibodies, anti-SCL70 antibodies. All these things will categorize a specific secondary problem that suddenly shows up. It is crucial that you do that. Again, I repeat, if you're not familiar with this and you don't know even what it is all about, there are plenty excellent rheumatologists in practice out there everywhere, and you should refer the patient there for them to help you out to see what's going on. If you list your own on, the patient becomes more and more symptomatic, and things become very chronic. And of course, you will proceed also sometimes to do a chest X-ray. You have to do a CT of the chest, MRI of the chest, esophagram, endoscopy, colonoscopy, abdominal CT, etc. And that's what we would do to try to diagnose the problem, to see what's going on. Let me give you a little example. Many years ago, before my hair were gray, I got a phone call on a Friday afternoon around 4:30 from a faraway place, and from a patient who was referred to me by another patient of mine that lived in that place, to tell me she needs help. Can I please help her? She told me she went to Atlanta, was up in Georgia. She was hospitalized for several weeks. They couldn't figure out what was going on. They scoped her all over the place. Then that didn't help her. She went back home. She continued to have between 60, 70, 80 bowel movements per day. Then she went to Washington, D.C. She was again hospitalized, scope, doing endoscopy, colonoscopy, because this woman was having between 70, 80 bowel movement per day. She had lost about 60 pounds, 70 pounds. Can't eat anything. As soon as she eats it, it goes right down. It goes right through her. So what is going on? Well, I listened to the story, and the hospital have an order sheet. I think there's about 32 different orders in it. So as I listened to her, I was checking the orders off as I was talking to her, and I asked her, "Can you travel to White Plains?" She said, "Yes, she can." I said, "Well, you could go to the Crown Plaza." I give her the name of the Crown Plaza Hotel to call to see if she could make a reservation. She said she could bring her mother with her. I said, "Fine, go right ahead. You get the appointment, you get the reservation, and I'll meet you at the White Plains Hospital Monday morning." Because I walked the orders over before 5 o'clock, gave them to the admitting people. I said, "This lady's coming." I gave the data because she had already been disabled for so long. She's now a Medicare patient. So I gave them all the material. She's going to be admitted Monday morning. Sure enough, Monday morning she was admitted. And when she was admitted, I met her at the hospital, examined her, and then I finished examining her and I evaluated her. And sure enough, this lady, I said to myself, what could be going on? Let me tell you a little bit about the anatomy of the GI tract. When you eat something, it goes through the mouth, through the esophagus, into the stomach. It must sit in the stomach for an appropriate period of time, and then different enzymes are released from the pancreas, etc., to help digest the food, depending on whatever you eat. And then the food goes back to the small bowel. It must, by necessity, remain in the small bowel for a specific period of time for the digestive process to continue. But for that to occur, you need to have smooth muscle in the wall of the small bowel that are functioning properly, so as to gradually, as the digestive process is going on, to be releasing that food product into the large bowel. Well, I figured, something is wrong. It's got to be in her small bowel, because as soon as she eats the stuff, it goes right through. They won't stop. Something's got to be wrong there with the smooth muscle. And I ask her about, I look at her skin's fine, there's no lesion on the skin, whatever. And I thought that something is wrong with this lady's small bowel. It's got to be a small bowel problem. In those days, very few, if any, uh, gastroenterologists in this country knew how to look into somebody's small bowel. She never got her small bowel evaluated. Now we have tests we could do for the small bowel. We don't even have to look at it. Those things didn't exist. I said to myself, well, let's do. I figured right away something's wrong with the small bowel. She was severely dehydrated. She had lost 70 pounds. Her BUN was 19, but when I tell you a little bit more of the story, I'll tell you what that means, a BUN of 19. Because she is protein starved. There's no way a BUN should be 19. It's 19 because severely dehydrated. Because you need protein ingestion in order to produce BUN, blood urea nitrogen. Hers were 19, the normal is up to 20, but hers that doesn't mean she's not dehydrated. And sure enough, when I hydrated her 2 days later, her BUN comes down to 2. I can't make this up. So I got some of my colleagues to do a skin biopsy for me. I did a skin biopsy, and then we sent it, I believe, to Columbia University, because they have a fantastic skin pathologist down there. And then, in fact, I remember the doctor who did for me, surgeon. Unfortunately, he used to practice at 170 Maple. He passed away. Did the biopsy. This was on Monday. But you got to understand this. I brought this with me. This is this lab sheet that has 290 different tests that I made together myself over the 43 years plus of practice. I accumulated it. There's no disease known to the world or to mankind that you cannot diagnose using this sheet if you know what it is you're doing. It so happened that a few months before, being the academic doctor that I am, the teacher, 2 tests had come out for a disease called scleroderma. But scleroderma is a disease of the skin. It causes abnormality in the skin that causes you to have a moon face, and you lose all this, the smooth muscle. You're staring at somebody, and your skin is usually all messed up. This lady's face is perfect looking. Her skin is perfect looking. But we did the biopsy. In addition to that, I ordered those 2 tests. I think I bring them here to show you. I ordered those 2 tests because they had just come out. Just came out into the world of medicine that it is the anti-centromere antibody, and it is the anti-topoisomerase antibody. Those just came out. They're positive when somebody has scleroderma. And sure enough, I had them already on the sheet. So I checked them off, and by Wednesday, even before I got the skin biopsy back, and I did an ANA, and I did all sorts of stuff, it turns out that the fact was positive. And then the test came back from the skin biopsy from Columbia, also positive for scleroderma. Because just because the skin is normal doesn't mean underneath the skin you don't have this process. So it turns out that I made a diagnosis from the top of my head on the telephone from this country, wherever she was, that this lady has scleroderma of the small bowel. That's why it's going straight through. It's not the smooth muscles and the wall of the small bowel are all destroyed. So the small bowel is like this is like a pipe, a hollow pipe. And as soon as the food gets there, it's go right through. There's nothing to contract it to stay there for the digestive process to take place. It's a true story. So as soon as the other stuff came back positive, even before the skin back project, I started on intravenous steroid as well as Cytoxin. Okay, so by the time, and I of course giving her IV fluid, giving her a lot of sugar in it, potassium replacements, etc. By the time the following weekend comes in, while the patient is getting better, you can't make this up. The patient is getting better. The tests come back. I put her on steroid. I put on Cytoxin, and I went to the hospital Saturday morning to look at the patient, couldn't find the chart. The chart was gone. Well, whatever. Maybe the chart is misplaced or whatever. I spoke to the social worker. I couldn't find the chart. So I took a piece of white paper to write my little note with my poor handwriting. It turns out that by Monday morning, the patient received a letter on their door that the hospitalization is being denied by the administration because they don't think that Dr. Alcena knows what he's doing and they don't agree with what he's doing. Therefore, they have the right on behalf of Medicare to deny the admission. If the patient stays in the hospital, she is going to be responsible for the bill. Okay, this happened, all right? That's Monday morning. However, when I get back to my office around 8:30, I got this phone call from the chairman of gastroenterologists from Mount Sinai Medical School in Manhattan. This doctor called me before. He said, I'm Dr. So-and-so. I'm the chairman of GI at Mount Sinai. I received your case. I said, what case was that? So he said, you don't know? So I don't know. It turns out that the hospital, this is a true story, and I couldn't care less, this is a true story, reported me to an outfit called IPRO. In those days, IPRO was violent. I mean, there was nothing terrible they wouldn't do to a doctor, okay, because they were reviewing, they were really brutal. They were so brutal, I think they've been pretty much eliminated. It was IPRO, I was reported to IPRO that I don't know what I'm doing. Then IPRO then took the case and referred it to the GI doctor who was in charge, the chairman of GI at Mount Sinai, to review. I knew nothing about any of this. Nothing like that until this gentleman said, Dr. Alcena, I'm calling you, number one, to congratulate you for making a brilliant diagnosis. I said, sir, what diagnosis is that? I said, you don't know? I said, I don't know. Well, he says, well, I got the patient's chart so-and-so in front of me. It was referred to me for review by IPRO. The people at Whiteman Hospital say you don't know what you were doing, and I just give you the case. And I'm telling you, this is the most brilliant diagnosis I've ever come in contact with in my years as a GI doctor. I said, really? He says, well, I'll tell you what. Everything you did was perfect. This is a brilliant diagnosis. I'm going to reverse the decision that was made at Whiteman Hospital to deny the patient the hospital stay, and I'm going to get in touch with them. And I want you to give him a message, and to give me the message, I cannot say it on television, but it was pretty ugly. As soon as we hung up, around 9:30 in the morning, I got a call from the administration at Whiteman Hospital. Their CEO, chief of medicine, want to meet with me at 11 o'clock in their offices. You can't make this up. So in the meantime, my patient is getting better. So I walk in there. I saw 4 doctors sitting in a room getting ready to literally lynch me. Literally. I mean, they were out to get me. They got me this time. And so I said, what is this all about? They said, well, we have the chart here. This is the chart that I couldn't find. We have the chart here. We disagree with what you're doing for this patient. We disagree with your diagnosis, and we wanted you to know that and discuss it with you. And I said, well, why didn't you talk to me before? I mean, you have the right. The chief of medicine can call me, say, Val, what's going on? But that wasn't the point. The point was to destroy me. So, and I said, by the way, I don't have to sit down. There was an empty chair. He said, why not? He said, I said, I got a message for you from Dr. So-and-so, the chairman of gastroenterologists at Mount Sinai, to tell you, you are a bunch of know-nothing S-head. You don't know what you're talking about, and he's reversing the decision you had made. And I walked out. To this day, I never said another word to them. I walked out. They were just like that. What went on after that, the guy was so brutal, the former CEO. He fired the chairman of medicine. That's right. This guy was literally on that day, the guy was no longer chairman of medicine. Because this guy, I mean, somebody who I had a lot of respect for and admiration for. I mean, you have no idea. I mean, this is a guy I like. I have a lot of. This guy could have talked to me. It turns out that no, he was part of the political. He was out to get me. I knew nothing about it, and I like this guy. We talk all the time. It turns out that it was all a setup. So the patient did extremely well. His diagnosis of scleroderma of the small bowel was confirmed. By the time the patient left the hospital, she was having 2 bowel movements per day. And the patient got, and I dictated a note, I won't tell you the ugly illegal story about the note that the discharge note that I dictated. I wouldn't tell you that. That would be inappropriate and unprofessional, but you could figure it out. I mean, it was basically criminal. So, but don't worry about it. I handle it. So this lady wrote this incredible. She had a beautiful handwriting. She was a two-page letter, 2 pages letter to the hospital, to praise the hospital, and praise the nurses, and praise me what I've done to save her life. This is a lady. She even where she is at, every 2 days she's at the hospital over there getting IV fluid because she was constantly having diarrhea. That's what was done to me. Okay, as a physician on the staff at 41 East Post Road on Davis Avenue. And she said, you can't make this up. It's an absolutely true story. And of course, nobody had ever heard of a diagnosis of scleroderma of the small bowel prior to that. But it was definitely there. It was diagnosed, the patient. And then to this day, as far as I know, of course, she told her to stop the steroid because there is no cure for scleroderma. This is why the disease is called systemic sclerosis. Scleroderma can go everywhere, not just the skin. It's a systemic sclerosis. That's what the word systemic means. So I diagnosed the lady, pretty much got her better. She put on 60, 70 pounds, went back to work, went back to work. She was waiting for the government wherever she stays at. And then I told her, of course, I stopped the steroids because I was treating her on the telephone long distance, to stay on the Cytoxan, and then how to decrease it, and how to manage the inflammation by watching the set rate, etc. And then that's the last I heard. I haven't heard from her for the last several years because usually I get a postcard from her every Christmas. I haven't heard from her for the last 3 years. This was done to me, and you can't. And then when I made that diagnosis, I wasn't half as smart as I am now. My hair was not even graded. Okay, that's what was done to me. This is right here. That is the reason why I am the only private physician independently left practicing medicine as we speak today at East Post Road on Davis Avenue in White Plains. When I came to this community, there were close 10, 12 minority physicians. I think there were maybe 10 blacks or 2 Latinos. They got rid of all of them. They harassed them, threatened them. They had to go because they needed the business. I'm the only one that cannot. And believe me, what I just told you, they've done 1,000,000,000 times more stuff than that to me. For doing nothing. For doing nothing. When I came to White Plains Hospital, originally all the doctors that were there were all people who trained at Montefiore. They welcomed me with open arms. In fact, I applied to Montefiore. I was approved in February before I even finished my training. My original approval date to Montefiore, to White Plains Hospital, was February of 1978, even though I was not going to finish until June 78. Those were so, in fact, one of the doctors there used to be my teacher. This doctor used to teach us in the clinic how to do physical exam. You can't make this up. This is what was done to me. And things that are 50,000 times more ugly has been done for doing absolutely nothing. I'm a human being. I can do wrong. They have not even allowed me to do anything wrong. And then following, and all that time, they don't know they were really hurting themselves. Because I have what you call the Valiere Alcena. I shouldn't tell you this, but I'm the most intelligently naive person that God has ever created. That is, you put 12 people in the room. Once I know the subject matter, I can tell you what's plan A, plan B, plan C, and plan D is, even though I was not in the meeting. That's the kind of brain I have. So they've done everything to hurt me, to destroy me. Not just hurting. Hurting is bad enough, but to really destroy, for doing nothing. This is the worst thing of it. For taking care of my patient and for having a black skin. I went to school at Einstein. The Jewish folks at Einstein took me in like I was their son because they know that I have a Jewish mother myself and a Jewish grandfather and a Jewish great-grandmother. The same thing at Montefiore. They did everything for me. They put the army on me. I became chief medical resident. They offered me a job with a lot of money when I finished my training in 78. I couldn't put gas on the car. I said no. Dr. Gilbert said, Val, you can't do this to me. I've been holding the job for you. I said, sir, I apologize. I'm flattered, but I can't do it. I don't want to work for anybody, even though I couldn't put gas in my car. And had I worked for anybody, I wouldn't achieve the things that I achieved today. But you got to get permission from everybody to do anything. In any event, I'll give you an example, a classic example. There are other examples. I'll give you a classic example what mixed connective tissue diseases can do. This is a life that was saved, and I have saved many more lives since then by knowing this, how to do this stuff. Okay, so you got to be very careful, very diligent, and very thorough when you finish examining the patient. And remember, there are some, I have here the sheets in my hand. The sheet is full of keys. You cannot open a door without the keys. There are dozens and dozens of keys on the sheet that you need to do to diagnose cases that other people cannot diagnose if you know what the keys are. Okay, nothing wrong with them. They're good doctors. But I was telling somebody the other day, just a few days ago, last Wednesday, who came to the office, he talked to his niece about work I'm doing for him. The niece said to him, I'm a good doctor. I said, that's not a compliment. He says, why not? I said, well, let me tell you how it is. The rule of the game is outstanding, superb, excellent, very good, good, and poor. I said, if you consider a good doctor, he said, I said, yeah, that's the grading system. It's outstanding, superb, excellent, very good, good, and poor. And I say I've always been categorized above the outstanding, no matter where I go. This is not bragging. This is the truth. Okay. As a matter of fact, if that weren't the case, I would have lost my license 10 million years ago because of what has been done to me at White Plain Hospital. Okay. So so this is what, and this is Jewish folks. I'm a Jew myself. I'm a black Jew, but my skin is cast black, and there are black Jews all over the world. This is how I've been treated for doing absolutely nothing because of jealousy and envy, because I have brain power, brain they could never have even if they lived to be 10 million years. So again, we're talking about this. I'm going to end up this series and talk about something else next week. This year now, this is the era of the COVID-19 infection pandemic. Be careful. Listen to the scientists. Put your mask on. Keep your distance. Put your glove on if you go into the supermarket or something where you're going to touch stuff. Wash your hand with sanitizer or soap for at least 20 seconds. This is real. This is no joke. This thing is a killer. So watch out. Don't go outside without your mask on, okay? Until I see you again, this is Dr. Alcena saying so long and bye-bye.